Welcome back, everybody. As you probably recall, in our last lecture, we began our journey down the very last section or area of psychology that we're going to be covering in this class. In particular, we introduced everybody to clinical psychology, covering some of the key elements to what clinical psychology is all about and how it kind of gets partitioned up into different topics and different things when we talk about the main goal of most clinical psychologists, and that's the therapy side of things. Well, in this lecture, we're going to start down our final journey where we start to explore specific mental health disorders. This is partially to give us a better sense of how clinical psychology works as a whole, but it's also something that's done in many intro classes because there's this recognition that knowing more about these things can help us maybe understand us and those around us better. And also, it can allow us to be more sensitive to others who are struggling with mental health issues, something that's a persistent problem in a large percentage of the population. And this is where I want to get started in today's class. To qualify that we're going to be exploring a lot of different avenues and topics in these lectures that encapsulates a kind of wide range of mental health issues. But I always want to start before we go down these paths with reminding everybody that everybody seeking therapy does not necessarily have to have some type of disorder like the ones we're discussing. Not only are we only covering a small subsection of all of the different types of mental health issues that could pop up, but it's really important to note that there are many individuals that seek therapy or are seeing a therapist on a regular basis that don't qualify necessarily as having one of the many disorders that is included in something that we didn't get a chance to talk much about called the DSM, or the Diagnostic and Statistical Manual of Mental Disorders. Right? Needing to seek help is not synonymous with having some type of diagnosable disorder. And it's also important to note that even if somebody gets diagnosed with a disorder, it doesn't inherently mean that these individuals are somehow broken or somehow kind of affixed with something that is a part of who they are or defines who they are. Unfortunately, stigma around mental health issues is a persistent problem and one that the clinical community has tried desperately to try to help with. And if we're looking for why this is such an important thing, understand that we have hundreds of years of people believing that those struggling with clinical issues were somehow contagious or afflicted by some type of spiritual thing. And this is in our terminology and lots of just our common misperceptions that people have of those that have been diagnosed with mental health issues. In fact, even in today's culture, many of us, because we don't quite understand how these disorders work or what's the best course of action for individuals who get diagnosed, tend to even conclude if they know more about science and that these things aren't contagious, that unfortunately people who get defined as having these disorders are really defined as such. And there's a lot of people, again, in the clinical community who have tried to find ways to separate out the disorder from the person. There's also large amounts of individuals that have worked hard to educate people, even in, say, an intro class like this, on the specific symptoms and manifestations of disorder so we can be not only more aware of these things for ourselves and others, but more sensitive to the topic when we think about how prevalent these things are and how they can afflict individuals in a number of different ways. So let's get started down this journey and let's focus our attention in this first lecture on a classification of disorders that we call anxiety disorders. Now, what are anxiety disorders? Anxiety disorders are an umbrella of disorders or mental health issues that involve some aspect of anxiety within them. Now, how that anxiety manifests itself can vary dramatically from specifically diagnosed disorder to specifically diagnosed disorder. We're going to cover three of the more prominent anxiety disorders in this lecture. The first one being generalized anxiety disorder, the next being panic disorder, and the last being by far the most prominent anxiety disorder out there, called phobias. Well, at least broad range of disorders that we call phobias. We're going to start with this lecture, though, on the very first one you see listed here, generalized anxiety disorder. And there's some logic behind why most instructors and textbooks start there when talking about anxiety disorders. Even though this is a relatively rare disorder in comparison to other disorders that we're going to discuss as we progress, many instructors and textbooks talk first about generalized anxiety disorder when discussing mental health issues relating to this umbrella of groupings, because it sort of looks like the hallmark of anxiety disorders on the surface. For people struggling with generalized anxiety disorder, they report having this constant free-floating anxiety that tends to latch on to thing after thing after thing. We're not talking about necessarily being just nervous about stuff that would naturally make anybody nervous. We're talking about these individuals having this powerful, overwhelming fear and nervousness around so many things that it makes life very hard to kind of function in. And what we tend to see for these individuals initially is they report high levels of jitteriness or tenseness, and they'll even report feeling this discomfort and this lack of, well, actually, this prevalence of tension that kind of operates on a daily basis for them. Now, what's interesting with this particular disorder is that for somebody to be diagnosed with it, they usually have to have these symptoms of anxiety for multiple months. By the time you get to 5-6 months, the typical cutoff for being diagnosed with generalized anxiety disorder, a lot of the kind of outward manifestations of this disorder have started to change and evolve. People very rarely look super tense and jittery when they're diagnosed with this disorder about 6 months to years after they've had these symptoms, and instead they look sort of tired and fatigued or unmotivated as a result of how much that stress and anxiety has been kind of a burden on them. So when people are found to be diagnosed with this through a wide range of different things, they're given multiple types of interventions to try to help. One of the classic interventions that's been used a lot in recent years is a version of cognitive behavioral therapy, where people are encouraged to really explore the thoughts and reactions that they have in different situations to kind of understand a little bit better where they might be able to fix that thinking or alter that thinking, I guess would be a better term, and in doing so lessen their anxiety across a wide range of different situations. And for people with very robust generalized anxiety disorder, oftentimes this type of treatment is paired up with some type of medication. And one of the more commonly prescribed medications even to this day for generalized anxiety disorder are different types of antidepressants. I know the term antidepressants might seem like it doesn't quite really fit into this category, but again, if we go back to the medication discussion that we had, you have to remember that many medications are pretty fast impacting and they affect a wide range of different things. So even though we tend to think of antidepressants as just for depression, they can be pretty darn effective for individuals who are struggling with generalized anxiety disorder. It's not, again, necessarily something that has to be prescribed to people, but it is in circulation for specific people. If we're looking for other things to take note of with generalized anxiety disorder, it is probably important to note that we think there's a biological factor at play with generalized anxiety disorder, but there's also specific groups within the population, possibly due to social constraints or other things, that are much more likely to be diagnosed with generalized anxiety disorder. We see women are about 2 to 3 times more likely to be diagnosed with generalized anxiety disorder by their clinicians, and people in lower income categories and people that report repeated relationship issues also are more inclined to be diagnosed with generalized anxiety disorder. Now, if we get into this a little bit deeper, we can understand that this is not quite as obvious and cut and dry as most of us probably think. Being a woman or being low income doesn't mean that you're destined to be more inclined to develop these things. Instead, what many researchers have argued is it's probably a byproduct of the stressors placed on these individuals who fit into these categories, in conjunction with the proclivity for clinicians and others to be more inclined to diagnose members from these groups with generalized anxiety disorder versus other things that they could potentially diagnose them with, or maybe they just push them past the threshold that they're close to as a result of their membership within these groups. Either way, what we do see is that only about 2 to 3% of the population in the US is diagnosed with this at any given time, but there are certain groups that have a much higher proclivity for being diagnosed with this at any given time. And this is going to be a theme that's going to be persistent throughout all of the anxiety disorders that we're going to be discussing. The next type of anxiety disorder that's out there is something called panic disorder. Now, on the surface, the name panic disorder looks a lot like generalized anxiety disorder. It's important to note that these two things are pretty separate issues, even though they're both anxiety disorders. The highlight to panic disorder is kind of in its name, these things that we call panic attacks, where people don't report constant free-floating anxiety, but instead these very powerful anxiety-driven responses to things in the environment. We talk in biological psychology about this thing called the sympathetic nervous system. You might know it better as the fight or flight system. Well, for people struggling with this panic disorder, this system is on high alert all the time, and more importantly, it's oftentimes overreacting to nothing. It just is triggered randomly. And in fact, it has to happen a number of times within a month, and there has to be issues with the potential for future ones for this to even be defined as a disorder. But those that get defined with this do struggle with this oftentimes for an extremely large period of time. What we see within the population is that, again, about 3% of the population is diagnosed with this, much like generalized anxiety disorder. There's some heritability factors for this, especially for people that develop symptoms at a young age, essentially under the age of 25. And women are, again, more often diagnosed with this. Now, why this is the case is, again, up for debate. There's the potential that there are genetic factors at play that could explain the gender differences. There's also, though, the potential that an inherent bias of people diagnosing individuals with this could potentially be the catalyst for these differences that we find. Regardless of what it is, though, we do see, at least in the US, that men are less commonly diagnosed with generalized anxiety disorder, panic disorder and generalized anxiety disorder than women. And much like we have multiple treatments for generalized anxiety disorder, we also have multiple treatments that are given for people diagnosed with panic disorder. Antidepressants and different types of therapy, especially in conjunction with each other, can be pretty darn effective. But another thing that's considered when we talk about panic disorder is just sort of riding out the wave. I might know that might seem kind of callous or almost lazy and a clinical side of things, but it's important to note that this specific disorder has been found to sometimes come in waves for individuals. And also, in conjunction with that, there's lots of individuals, because their day-to-day functioning isn't that atypical, that don't like the prospect of having to take a medication or involve themselves in lots of therapy when, more often than not, when they're having panic attack issues, they're functioning at a level that they think is optimal. They're not having the depression or the constant anxiety that we see in generalized anxiety disorder, or what we'll talk about later, called depression. So trying to kind of find the good pairing, trying to find the best projections of where somebody's going to go, is a constant conversation for those that are diagnosed with panic disorder after manifesting these symptoms relating to, again, these things called panic attacks, which can be very multifaceted. And these panic attacks that involve things like rapid heartbeat and frantic breathing, and sometimes this feeling like walls are closing in on you, are also prominent in another type of anxiety disorder out there that we call phobias. The key issue here is that phobias are very directed at something in particular, where panic disorder is just kind of this broad, generalized thing that seems to just pop up sort of at random for individuals. Phobias definitely don't feel random for those that suffer with symptoms relating to this specific disorder. And unfortunately, when we look at the population, we do see a large number of individuals who have these very robust reactions to specific things, essentially the equivalents of panic attacks, that take up enough of their life that require them to possibly seek out therapy and try to find ways to minimize the effects that these phobias can have on individuals. Now, obviously, there's a large range of different types of phobias, so it's tough to talk about specific statistics, but what we see is that out of the anxiety disorders as a whole, all phobias combined are much more commonly diagnosed than any of the other disorders that we've talked about. We also see that these are very comorbid with other types of disorders out there. That could be generalized anxiety disorder, could be panic disorder. It could also potentially be things like depression or other problems that we don't have a chance to visit within this class. And when we look at this particular disorder, we again see that there are components that lead to higher rates of phobias, even though they're not nearly as robust as some of the other ones that we've looked at. And much like some of the other types of disorders that we've looked at, there are lots of different treatments that are available. As I mentioned in our previous class, behavioral treatment has proven to be a pretty darn effective way to help individuals diagnosed with phobias. Cognitive behavioral therapy, another thing that we've talked, is also proven to be very effective, especially for specific types of phobias that are out there. However, if somebody is so unbelievably overwhelmed by their phobia that these types of treatments cannot be effective, there are some pharmacological interventions that have been developed over the years that seem to not necessarily do the trick, but at least get people on the path to being able to find ways to help themselves. Most of the pharmacological therapies don't usually involve antidepressants anymore, but instead tranquilizers and other types of things that sort of just calm the system down are the ones that tend to be used in this case. Even though it is important to note that antidepressants are sometimes, depending upon the phobias, used for individuals who need some type of pharmacological aid. It's also important to note when we talk about phobias that there's been a lot of research that's tried to figure out the source of the specific types of phobias that develop. Researchers for centuries have been baffled by the fact that phobias seem to have certain things that they're innately tied to. Snakes, spiders, heights, enclosed spaces. And obviously, we have a couple random phobias that might pop up occasionally, but more often than not, what researchers are amazed by is how specific types of phobias do seem to manifest themselves and how prominent they are in the population. They're not something that's as common as we might think. I know many of us have things that make us uncomfortable or we get nervous around. It's important to note that the bar is pretty high for people to get past the threshold of those things making them uncomfortable to being defined as having a phobia. But, nonetheless, there's a decent amount of the population, about 1 in 10 of us at some point in our life, will be diagnosed with a phobia. And trying to figure out where those things are coming from has been a key source of interest, since, again, they seem to be very specific. And what lots of individuals have discovered through different types of data analyses is that we do seem to have biological predispositions for not only developing phobias, but developing specific types of phobias. And this has actually been something that's been looked at extensively by diathesis stress researchers that we talked about in our previous lectures. Those looking for kind of the biological and environmental combination that has to come together for a mental health issue to start to emerge. Diathesis, again, being the biological aspects, and the stress being the social components. Two researchers that have really championed trying to find these combinations and what leads to issues are Susan Minica and Albert Bandura. Minica is especially famous in the clinical community when it comes to her work on phobias, because what she was able to show is that certain species not only do have a proclivity to develop these things, but another key component that's required for many phobias to emerge is some type of social interaction, some type of exposure to another individual displaying the phobia. Her most classic study that she ever ran compared the behaviors of monkeys with respect to how they reacted to a fake snake after they had either seen another snake display a fear of it, or just another monkey display a fear of the snake, or just have the monkeys kind of exposed to the snake without seeing any other monkeys. Minica was able to show with great depth that essentially that the viewing of another monkey being terrified of a snake could cause the vast majority of the snakes within her labs to show this strong, robust fear reaction to snakes. Now, whether or not that translates perfectly to the development of phobias is debatable. In fact, it has been debated by many clinical psychologists. But many have argued that if we have repeated exposures, then these things could start to manifest themselves in late adolescence and into adulthood and become eventually what we would consider a phobia. Now, this I say my learning idea has also been incorporated in research to show that you could potentially use social learning to sort of desensitize people to phobias or get them to not be as inclined to developing phobias. One of the champions of this was somebody we mentioned earlier named Albert Bandura, that personality psychologist who focused a lot of his research on modeling and how important exposure at young ages were to things, where we could look at how not only our individual differences emerge, but sometimes maybe our more quirky behaviors. And this type of research is still going on today, if you're wondering, and it really highlights some of the other avenues that clinical psychologists can go down beyond just trying to help people with problems. Trying to understand the sources of them and certain things that we need to know that can make treatments more effective is a big thing for clinical psychologists these days. Now, I think this is probably a good place to wrap up the anxiety disorders section of this. It's important to note that we didn't necessarily get to everything. And what we covered were three types of anxiety disorders, each with their own prevalence, each with their own symptoms, each with their own treatment combinations, and each having the potential to not exist only on their own, but be something that could be comorbid with other types of disorders. Again, it's really important at this point to stress that if you yourself find yourself struggling with specific symptoms and think you might qualify as having a disorder, you don't run off and diagnose yourself and try to treat yourself with this thing that you've decided you have, or this thing that you maybe decided your parents have or some friend has. To get into clinical psychology, there's years and years of training involved. Being more aware of these things can be helpful, but I don't want anybody knowing just a few facts about these things to go off and try to help their family members during the holiday break or during some time where they get an extensive amount of exposure to a friend or person that they are suspicious might have a problem. It's also important to reiterate now that even if somebody is diagnosed with these things, or if you're diagnosed with these things, this is not a life sentence, and this is not an indictment on the individual. People who are struggling with these things are people, and their symptoms are things that they're struggling with on a regular basis and are in desperate need many times of trying to find ways to overcome a lot of these struggles and challenges. And hopefully, since we've gone through this now, we have a better sense of the nuances to some of the more prominent anxiety disorders out there, and some of the different things that clinical psychologists have explored with regards to the kind of cause and treatment of a lot of these issues. This is going to be the same idea that we're going to have as we progress to the next branch of clinical topics. What is that next grouping that we're going to look at? Well, the next grouping that we're going to look at in the remainder of this lecture and a lot in our next lecture is this grouping that we call mood disorders. Much like anxiety disorders, the name kind of gives away what this umbrella classification of disorders focuses on. For anxiety disorders, it was the anxiety. For mood disorders, it's, well, sort of mood. We like to think of it as positive or negative affect, where people's moods are more extreme than they would usually like, and it tends to cause problems in their ability to function. Now, how people's moods can be affected with mood disorders, much like with anxiety disorders, ranges dramatically from specific mood disorder diagnosis to mood disorder diagnosis. The one that we're going to be focusing on in this class is by far the most prominent mood disorder out there, and actually the most prominent disorder that we know of to date, called depression. But there are other types of mood disorders that exist that have their own quirks to them that we'll be looking at in our next lecture. In particular, we're going to be looking at seasonal affective disorder, persistent depressive disorder, what used to be known as dysthymia, and bipolar disorder in our next class. But for the remainder of this lecture, since we don't have a lot of videos, we're going to spend just about 10 or 15 minutes talking about the most prominent mood disorder out there, and one that many intro to psych instructors have insisted we do want to really slowly work our way through because of how prominent it is and how many factors linked to it are really critical in, say, an incoming freshman's life. So let's look at depression in greater depth. What is depression, first of all? Well, defining depression is very, very challenging. And that's because depression is kind of a wide-spanning, multifaceted mood disorder that people struggle with. When we think of depression, we tend to think of people that are persistently sad and not very motivated to do stuff, and oftentimes having issues with just the way they feel about themselves and the world around them. This is definitely a common theme in many people struggling with depression, but none of these things are necessary to define somebody as being diagnosed with depression. And in fact, there's other things linked to depression that are equally important. Sleeplessness issues, anxiety issues even sometimes, irritability to an extent. All of these things are common symptoms that pop up in individuals diagnosed with depression. Another thing that has been inevitably tied to depression over the years is what we call suicidal ideation. This kind of desire to commit suicide, or just this notion of ending one's life being this kind of interesting path or option that in some cases is considered by people struggling with depression to be this ideal or this amazing option that could potentially be pursued. Historically, people have used suicidal ideation as this cutoff to whether or not you are capable of being diagnosed with depression. They've insisted that, look, all of us feel sad sometimes, but unless you're thinking about suicide, you probably don't have depression. Well, clinical psychologists have worked very hard over the years to try to dispel these misnomers. Obviously, somebody struggling with suicidal thoughts should probably be diagnosed, well, not diagnosed, but assessed for whether or not they have depression or struggling with depression at the time. But many individuals struggling with symptoms of depression don't necessarily have these suicidal ideations. They don't have these thoughts that are constantly floating through their heads. It doesn't mean that they can't be diagnosed with depression, that they can't be helped through therapy. It's sort of overcoming that bias, that assumption has been something that many researchers studying clinical psychology and depression in particular have strove to do over the last couple decades. But, with this wide range of different types of symptoms and issues that pop up, one might probably expect that this is something that's going to be diagnosed a lot. And in fact, in the United States, a good 8-10% of individuals are diagnosed with this at any given time. Some estimates have actually suggested that it's over 10% of the population is diagnosed with depression at some point in their life. Now, the catch with this particular disorder is it's tough to talk about worldwide rates of depression. In the United States, we're often well over 10% of the population being diagnosed with some type of depression, be it mild, moderate, or severe. In other countries, this is not nearly as common. So we say that depression is found in roughly 7% of the population in the US, but this varies from group to group and community to community and who's willing to get diagnosed also. What we also see with depression is that within groups, in particular across genders and other things, we see there are differences in who's more inclined to be diagnosed. For depression, women are diagnosed about twice as often as men. Again, this is something that's very tough to try to figure out why this is the case and whether or not this is a bias in the therapists or the environment that people are creating or genetics or kind of a combination of all three. But this is something that does pop up in research and is a constant discussion as to kind of why these differences are here. Now, I know many of you at this point might be asking, well, what's the deal with women being diagnosed with all of these disorders significantly more than men? I promise you this is not a universal thing. There are other disorders where men are diagnosed significantly more than women. So things don't necessarily become completely balanced out by the end, but they are much more balanced out than they might be perceived right now at this moment. And, when we're looking for, again, where these things are coming from, those statistics lead to the questions of why. Right? What's the thing that leads to depression? Well, we do know that there are some pretty big genetic components to depression. And we know that there's lots of early family exposures that can greatly increase a person's proclivity for developing depression. So oftentimes you'll hear clinical psychologists talk about how depression is a very family-linked thing. And that kind of gives the suggestion that it's not just your biology that you're inheriting, but the world that you're growing up in, the environment that you find yourself in at a young age, that can be a big precursor to the increased or decreased likelihood of developing depression symptoms. We also know that when people start manifesting symptoms of depression, we see their brains starting to sort of function in a different way. When we look at the structures of the brain that tend to be related to mood, what we see oftentimes in the brains of these individuals is that they have lots of what we call atypical neurotransmitter levels. More often than not, this is a lack of neurotransmitter levels, which, if you need a kind of crash course or reminder on this, what that means is the cells in those areas of the brain are not working as well as we'd like. They're not as active if there isn't much neurotransmitter. Because remember, neurotransmitters are the chemicals used for cells to communicate with each other. Now, another thing that's important to note here with depression is that this does seem to be something that we can have a proclivity for, but much like the diathesis stress model suggests, it tends to be specific life events, things that are the catalyst for the manifestation of symptoms of depression that get people usually past a certain threshold where they're no longer just kind of sad or unmotivated or having kind of thoughts that are not productive, and to the point where they're now really struggling with daily functioning as a result of a lot of these symptoms. Those life events can vary dramatically from person to person. Sometimes it can be a bad breakup, other times it could be a catastrophe, other times it could be just something that's been repeatedly happening to a person for long enough to where depression starts to emerge. And when it emerges, again, it can emerge in a lot of different ways. And this makes trying to tackle how to treat depression a very challenging thing. Now, what many researchers have shown is lots of alterations in the day-to-day functioning of individuals, especially those struggling with mild depression, can be very effective ways of helping people with a multitude of symptoms linked to depression. Encouraging regular sleep patterns where people try to get to bed at a more normal time, which for college students, I know normal gets a little skewed, but we're talking 9, 10 o'clock at night, and then getting up at a normal time, which is, 6, 7 in the morning, is something that can have a very impactful change on a person's thoughts and moods. Diet changes have also proven to be a very effective tool against mild depression, where having somebody find a way to balance out their diet and get proper nutrients in their bodies can be sometimes sufficient to help individuals with numerous symptoms of depression. When you pair these things with exercise, getting out, getting the heart beating, kind of regulating the system a little bit better, you can see a triad of things that can be used to help individuals, especially those with milder depression, overcome their problems without even needing to necessarily seek therapy or take some type of drug intervention. Now, this is not necessarily a universal thing. It's important to note that. But the fact that this has proven to be very effective, these three things, especially in combination, has also led lots of researchers to ask whether or not these issues could be the sources of depression in the first place. And one of the places that many people often get diagnosed with depression is when they get into college. And this could be because they're kind of on their own and finally able to recognize that some of their mood issues do need to be addressed, but some have been suspicious that when people get into college, they do a whole myriad of things that tend to take something that they might have a proclivity for and push it past a specific level. College students are inherently known, as I mentioned, for having just horrific sleep pattern hours where they might go to bed 2 or 3 in the morning on a regular basis and be forced to get up at 6, 7, 8 in the morning for certain classes that they have to take. And those limited hours of sleep are often offset by the occasional naps that people take. But all of these things can really be horrible catalysts on the body that could potentially lead to depression symptoms. College freshmen are also well known for making questionable diet choices when they get into college. You don't have meals that are prepared for you or people that kind of put you on a specific schedule and you get to eat sort of whenever you want. You tend to, especially when you're young, not always make the best decisions. I remember myself as a college student having the local pizza places on speed dial and getting pizza probably 5 to 6 days a week as a college freshman. That obviously, in hindsight, was not the best choice for me and my health. But this is a common theme, right? When we get that independence as college students, we sometimes don't make the best choices for what food we put in our bodies. And at the same time, many individuals don't make the best choices on whether or not they're going to exercise as regularly as they should when they get into school their freshman year. Again, this doesn't mean that all people coming into school because they're doing these things are guaranteed to struggle with depression symptoms, but when you pair these things with stress, there's probably a good reason why there is a pretty dramatic uptick in cases of depression when people get to about that college age and start to kind of operate independently of their families. So these things, again, are not only sources of help for people, but they could be sources of problems in the first place. If these things are not sufficient, There are other types of treatments that have proven to be very effective tools when it comes to a multitude of symptoms, again, linked to depression. There are numerous drug interventions that have been designed over the years, but one of the classic ones that are still in circulation today in different versions are these things called SSRIs, or selective serotonin reuptake inhibitors. And they're operating under the assumption that the sections of the brain that are using serotonin to help with mood regulation and thought regulation just oftentimes need a little extra help, where they don't reuptake the serotonin put into synapses so fast that it prevents a cascade of other neurons using serotonin to kind of catch messages and propagate those along multiple pathways within the brain. It's still a little challenging, even for neuroscientists, to truly understand what these drugs are doing to the brain as a whole, or why these drugs would be necessary in the first place, but there has been a great deal of research to suggest that these drugs can work fairly well for specific individuals, and they can sort of offset some of the atypical brain functioning that we see with individuals struggling with, again, a wide range of symptoms when it comes to depression. Doesn't mean that everybody should be taking these, though. It's an important thing to highlight. It doesn't even mean that all people diagnosed with depression should be taking these things. But it is something that we do need to take note of when talking about things that have proven to be fairly effective with at least the symptoms linked to depression. Another thing that's important to note is that there's a wide range of different psychotherapies that have proven to be pretty darn effective for depression. In fact, many individuals have often pushed recently to really gear the different types of psychotherapies that are used for individual depression based on the kind of individualized issues that are kind of revolving around the depression symptoms that people are struggling with. So if their depression symptoms came about through some type of loss or some type of stress in, say, a romantic relationship, or some type of issue around school or anxiety, well, then the psychotherapy used should maybe try to cater to those specific problems that the person's struggling with. But again, regardless of the type of treatment that's out there and the specific one used, these things have proven to be pretty darn effective. Another nice thing to mention when it comes to depression is that even though this is extremely common, diagnosed in a lot of individuals, lots of people do eventually get to the other side of the symptoms of depression. And they start to report remission of a lot of different symptoms, and they start to feel better regardless of whether or not they're taking medication or they're seeking therapy. But it's also important to note that even though many individuals diagnosed with depression get to the other side, that doesn't mean that everything is kind of done. There's been numerous studies to show that what we call remission rates for individuals diagnosed with depression, that the likelihood of struggling with symptoms again that gets people past the threshold of being diagnosed with depression, are very high. It means that if you've been diagnosed with depression once, if you had the symptoms, your chances of being diagnosed again at some later point, especially if there's some type of catalyst again, is pretty high. And trying to figure out how to get people out of that cycle, trying to figure out why these things are so common, is, again, something that many people in the research world have been obsessed with over the past few decades as they try to unravel and explain these things that we call depression and other mental health issues, partially because we want to do away with them, but also because understanding them more helps us understand the person that's really struggling with these symptoms. And that's kind of a good place, I think, to close out. This notion that, again, we're learning about these things not just to know about them and to look at them, but to really remind ourselves that those struggling with these symptoms are people, and they are simply people who are having issues with mood or thoughts that require some type of intervention. And if they get that correct intervention, they're feeling better, then they can kind of continue being people. Not that they're actually not people when they're struggling with these symptoms. It's another thing that's very upsetting to people in the clinical community. This notion that individuals who are diagnosed with something are somehow less than people, or they're not who they are because they have these symptoms. There's a lot that goes into this, and hopefully from what we've covered today, you now have a little bit better sense of certain disorders and also a greater appreciation of just the kind of wide range of things that those in clinical psychologists look at as they're trying to help people with not only the problems they have, but the societal things that are tied to them. We're going to continue this journey and this discussion in our next lecture when we get into more mood disorders, and then also talk about a not very common but very well-known disorder in schizophrenia. So I'll see most of you then. Take care.